Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series in neurology, today we are going to deal with one of the very interesting topic we call encephalopathy. The meaning is very simple. Encephalo means brain, pathy means involvement of that structure, that is we call involvement of brain. So brain, if it is involved either because of stroke or because of hematoma or because of hydrocephalus, normal pressure hydrocephalus, or because of drugs, Wernicke's encephalopathy, epilepsy, non-epileptic seizures, hypertensive encephalopathy, infections, etc. All these are included in encephalopathy. So any involvement of brain will be included in encephalopathy. We'll be discussing under this heading because this becomes a very close differential diagnosis of many conditions, but one of the most closest condition is encephalitis. So encephalopathy is a term which describes any disease of the brain that affects the structure and function of the brain. And because of involvement of the brain, we call cerebrum or cerebral hemisphere, person can have coma, that is total or near total unresponsiveness. A person may have stupor, where person can be aroused by deep painful stimulus. Obtundation means not a severe, and sometimes he responds to a touch or a voice. Lethargy or somnolence is arousal is decreased, but patient maintains the arousal spontaneously with a light stimulation. Spontaneously or with a light stimulation. Confusion is a term very frequently utilized in encephalopathy, where person has got impaired and attention, but person can be adequately aroused to perform certain mental status test. That is typically included in encephalopathy. While delirium is confusion plus period of agitation. So person is confused plus agitation, where person can be hypervigilance, irritable, and person can get even hallucination, and alternating period of decreased arousal. These are all the different terminology which you can come across in encephalopathy. Indirectly, we use the term altered mental status. So this can be all the finding in altered mental status, right from coma, stupor, obtundation, lethargy or somnolence, confusion, delirium, etc. These are all included in altered mental status. Short form we call it as AMS. Classification of encephalopathy can be divided into temporary, or it is also described as reversible, because person becomes absolutely normal after treatment or on its own, or person develops irreversible damage, we call permanent. Etiology wise, congenital and acquired. So the most common cause of encephalopathy can be hypoxic or ischemic. It is also described as hypoxic ischemic encephalopathy. Second very common is metabolic, which can be because of liver pathophysiology, we call hepatic encephalopathy. Because of renal, we call as a renal encephalopathy or uremic encephalopathy. And it can be also because of diabetes, particularly because of metabolic disorders in diabetes like hypoglycemia or diabetic ketoacidosis or hyperosmolar coma. They all will be included in encephalopathy. Certain toxic drugs can also produce encephalopathy. Among vasculitis, particularly in SLE, then stroke, Bassett syndrome, subarachnoid hemorrhage, subdural hematoma, epilepsy during non-convulsive phase, we call postictal phase, nutritional deficiency like Wernicke's encephalopathy, and which can also end up into Wernicke's Korsakoff encephalopathy, systemic infection like cerebral malaria, traumatic brain injury, malignant hypertension. Now it is the other term which is being utilized is hypertensive emergency, where you can have hypertensive encephalopathy, PRES, we call as a posterior reversible encephalopathy syndrome, or we call as RCVS, that is reversible vasoconstriction syndrome. So that is called RCVS. Then you can have mitochondrial cytopathy like Ray's syndrome or MELS syndrome, Hashimoto's encephalopathy, paraneoplastic encephalopathy, etc. This is a big list. You can divide into vascular, toxic, epileptic, traumatic, etc. So this can be divided into vascular etiology, toxic or metabolic, which will include hypoglycemia, hyperglycemia, electrolyte imbalance like hyponatremia, hypernatremia. Then ammonia will be disturbed in hypertensive or hepatic encephalopathy, uremic encephalopathy, Wernicke's encephalopathy, and because of some drugs, we call drug-induced encephalopathy. And among epilepsy, subclinical status epilepticus, frontal lobe epilepsy, and PRES, posterior reversible encephalopathy syndrome, and also as RCVS, reversible vasoconstriction syndrome. So vasoconstriction syndrome. And among traumatic, subdural, epidural, maybe even major fractures can lead to fat embolism. All this can also produce encephalopathy. So there are very lot number of causes. These are some of those which are very, very common in your everyday practice. Apart from all those, we can put them into certain other groups like transmissible spongiform encephalopathy, which is genetic disorder which is caused by prions. So you've got certain genetic disorders, hypoxic encephalopathy, carbon monoxide encephalopathy, severe head trauma, either because of multiple trauma or because of head injury, Wernicke's Korsakoff syndrome, Hashimoto's encephalopathy, uremic encephalopathy, toxic metabolic, delirium tremens, end-stage dementia, etc. Hepatic, methanol, hypoxic ischemic, hypertensive encephalopathy. These are lot number of causes which can be there. And do not forget psychogenic, where there is no damage to brain, but person mimics altered level of consciousness. There is also one variety of congenital variety we call mitochondrial encephalopathy, GLYCINE encephalopathy. So you can divide into two big groups, supratentorial, infratentorial, and among extracranial groups, metabolic disorders, etc. So whatever cause we have mentioned before, you can divide them into supratentorial and infratentorial. In supratentorial, good number of time it is asymmetrical and focal finding, while in case of infratentorial you will have brainstem with a crossed finding, means on one side lower motor neuron, on opposite side upper motor neuron, with cranial nerve involvement, cerebellum, etc., cerebellar signs, etc. While in the metabolic disorders, usually it is a non-focal, by and large generalized with intact brain. Means in this metabolic disorders, you will not have cranial nerve palsy. It will be usually bilateral. So that will be very peculiar in case of a metabolic group of disorders, which is usually non-focal, bilateral, and all the brainstem signs, that is including vestibulo-ocular reflexes, all those reflexes will be normal, meaning doll's eye movement, caloric taste, vestibulo-ocular reflexes, all those will be normal. You can also use the word acute and chronic. Among acute, CNS infection, trauma, hypoxic ischemic, autoimmune, metabolic disorders, seizures related, hypertensive complications, raised intracranial pressure. They are usually acute, but tumor and malignancy, good number of time it is chronic. Wernicke-Korsakoff syndromes, quite common. It is very frequently because of nutritional deficiency, and it can be because of persistent emesis like hyperemesis gravidarum, bariatric surgery, intestinal obstruction, starvation conditions like schizophrenia, prisoners, anorexia nervosa, iatrogenic like IV hyperalimentation, chronic hemodialysis, diuretics. You can get also in case of uremia because of markedly decreased appetite, chronic alcoholic and nutritional deficiency. That will produce Wernicke's encephalopathy and can end up into Wernicke-Korsakoff syndrome. As far as encephalopathy is concerned, there is usually involvement of either a brainstem or reticular activating system, which we call as a thalamocortical radiations, which is very commonly affected. By and large, the excitatory input, which bypasses the thalamus, can be involved, and that will be having different neurotransmitter substance like acetylcholine, serotonin, norepinephrine, dopamine, histamine, etc. And because of this involvement, the activation of brain is not there, what is being normally required, and that will produce altered mental status. So a person may be fully awake if one hemisphere is involved. So there is intact reticular activating system. So person can be awake in spite of the cerebral damage. But even in a unilateral damage, if the damage is more, it can produce raised intracranial pressure secondary to cerebral edema. And secondary to cerebral edema, there will be shift of mediastin, shift of the what we call as fox cerebri and herniation, and it can end up with altered level of consciousness, and person can be even unconscious, or we call coma. That can happen even in unilateral. Some of the common features in general in encephalopathy will be confusion, fatigue, forgetfulness, lack of concentration, behavior changes, thinking problems, etc. Together we put them into altered mental status. Person can have seizures, tremors, involuntary twitchings, which is very commonly seen particularly in hepatic coma, uremic encephalopathy, and also in case of a carbon dioxide narcosis. Person will also have muscle weakness, difficulty in speech, eyeball movement may be affected. And if person with Wernicke's encephalopathy is not treated early and completely, person can end up into Wernicke's Korsakoff syndrome, which almost becomes irreversible damage. There is one genetic disorders where prion proteins becomes abnormal. So it is described in a group called transmissible spongiform encephalopathy. Short form it is called TSE. There is a collection of what is called as prions, and these prions levels are elevated, and that can produce congenital or genetic encephalopathy. And some of the conditions which produce such disorders is Kuru, chronic wasting disease, Creutzfeldt-Jakob disorder, short form called CZD, and you can have a fatal familial insomnia. These are some of the disorders where prion levels are abnormal in brain, and that will produce encephalopathy. There is one variety of a disorder called as a glycine encephalopathy, which is again a genetic or we call inherited disorder, in which there is abnormal elevated level of glycine, which is one of the amino acid in brain, and that will result into encephalopathy and abnormal mental status. One another very common group which we come across is chronic traumatic encephalopathy, which is very common in the person who are boxer, very common. Another very common is in a football player, where the chance of head injury are much more. This type of encephalopathy occurs because of multiple trauma or injury to the brain. This blows to the head lead to a nerve damage. So there is an irreversible damage to the nerves, or we call neurons, and person ends up with chronic traumatic encephalopathy. Very common in case of a boxer. Classical example is our boxer called Khali. There is even Muhammad Ali. There is another disorders which is a rare variety of encephalopathy, which is because of autoimmune mechanism, which is very commonly seen in a Hashimoto's disease. Also, apart from attacking the thyroid gland producing Hashimoto's, it also involves brain, and then it is called as a Hashimoto's encephalopathy. Quite common, so it is one of the differential diagnosis of autoimmune encephalopathy, and we do come across this particular group in our everyday practice. One of the another very common encephalopathy is hypertensive, where person suddenly has got elevated level of blood pressure. Usually the earlier term was described as malignant hypertension, but now that term is not frequently utilized. The common term which is being utilized is hypertensive emergency, where because of sudden elevation of blood pressure, person can end up with hypertensive encephalopathy. And there are two other terms which are very frequently utilized, that is press posterior reversible encephalopathy syndrome. Another is RCVS, which is called reversible cerebro-vasoconstriction syndrome. So that is called RCVS. These are all secondary due to hypertensive encephalopathy, or we call hypertensive emergency. They will be part and parcel of those. Toxic metabolic will be very common whenever the brain gets damaged because of either infection, toxins, or failure of organ. Classical example of failure of organ is hepatic encephalopathy, uremic encephalopathy. These are the two classical examples where in hepatic ammonia plays a major role, while in uremic encephalopathy elevated level of urea plays a major role. You can have also encephalopathy secondary due to infections or maybe secondary due to some toxins. Also electrolytes like hypernatremia can be another very common etiology producing encephalopathy. Also you can have a toxic metabolic because of hormonal imbalance or maybe because of acid base imbalance. These all are put together into a group toxic metabolic encephalopathy. And this will be usually involving both sides of the brain, so it is a generalized signs. So person will have a generalized symptoms and signs. Person will have an altered level of consciousness. Even hypoglycemia, diabetic ketoacidosis, hyperosmolar coma, etc. will be also part and parcel of this toxic metabolic encephalopathy. So one of the part of toxic metabolic is uremic encephalopathy, we have already mentioned, which will be very common either in a case of CKD or AKI. And this will be the mechanism of uremic encephalopathy. So these are different uremic toxins which will be there apart from urea level being elevated. There will be alteration of the blood-brain barrier system. Gut microbiome alteration will take place. Aquaporin channel dysregulation takes place in blood-brain barrier system. There will be cerebral catecholamine derangements, inflammation and oxidative stress, electrolyte imbalance, metabolic acidosis, amino acid dearrangement in a neurotransmitter substances, and finally it will end up with uremic encephalopathy. More common with both the groups like AKI and also in case of end-stage liver disease or end-stage kidney disease, or we call CKD, particularly stage 5. Very, very common. Carbon monoxide poisoning is another very, very common which can happen. It is very common because of smoke inhalation and poor functioning heating system, where carbon monoxide will enter into the blood, will produce carboxyhemoglobin and will produce hypoxia, severe hypoxia, and person will develop confusion, headache, and will have an altered level of consciousness right up to coma. Even person can develop myocardial ischemia. Carboxyhemoglobin level will be more than 15%, and person will have typical finding of carbon monoxide poisoning in the form of a CT scan will show you a very peculiar finding, and person can have even what we call as flapping tremors, and person should be treated with hyperbaric oxygen, and blood will be pinkish in color. There is another group we call as a methanol poisoning, and this methanol poisoning is very commonly because of consumption of a preparation which contains large quantity of methanol. Particularly in India we call as desi daru, or alcohol which is prepared usually in villages where it contains large quantity of methanol. Also you can come across methanol poisoning because of antifreeze mechanism. There is a compound which is containing good quantity of methanol, and in a moonshine liquor also there is a large quantity of methanol, and that will produce methanol poisoning, and it will end up with, because methanol will be converted into para-aldehyde, and that will produce high anion gap metabolic acidosis, And treatment will be, you will have to give ethanol or fomepizole, which will inhibit the alcohol dehydrogenase. So the methanol breakdown will be prevented and conversion into formic acid and formaldehyde will be prevented. So this will require alcohol or ethanol as a treatment for methanol poisoning. And you can have typical damage to the retina, which is called as a bull's eye. Hepatic encephalopathy, we have already mentioned, it will be because of acute liver damage or a chronic liver damage, where you will have an excessive collection of ammonia, and that will have bad effects, and plus there will be lot of other toxins and metabolites which will have effect on a cerebral hemisphere, producing hepatic encephalopathy. So cirrhosis and acute liver failure becomes one of the most common, and another is photosystemic shunts, very commonly TIPS, and other we call as photosystemic anastomosis, where person will very frequently develop asterexis or flapping tremors, which are very common, and ataxia, nystagmus, hyperreflexia are also common. Person will have altered mental status, altered behavior, and it is diagnosed by elevated level of ammonia in blood as well as in CSF. So this will be a very easy way of identifying. Plus CT or MRI will be helpful to show you the damage to what we call as a lentiform nucleus or globus pallidus. So there will be lot of different compounds which can result into damage to hepatic encephalopathy, like ammonia, glutamine, and there will be some of the risk factor which will increase the chance of hepatic encephalopathy, like infection, GI bleed, constipation, high protein diet, zinc deficiency, excessive use of diuretics, benzodiazepine, etc. So you got ammonia production which will not be metabolized by liver, and because it is not metabolized, it will bypass via photosystemic shunt and will have effect on brain, producing hepatic encephalopathy. So hepatic encephalopathy will be very frequently in acute liver damage as well as a chronic liver damage. Gut flora will convert these different compounds into ammonia, and you will have excessive level of ammonia, glutamine, nitrogenous products, GABA, etc. This is in detail the pathophysiology of hepatic encephalopathy. You can undergo at your leisure time. So I am keeping for some time. You can go, because this can be asked in your oral and as a short note also. That is pathogenesis of hepatic encephalopathy. This slide will show you what are the common conditions: photosystemic bypass, severe liver damage, etc. And then what happens at different levels, and what will be the clinical symptoms and signs. And you can divide into grade 1, grade 2, grade 3 and grade 4. So entirely regarding hepatic encephalopathy. I am not going into detail at present. So you can divide into grade 1, grade 2, grade 3 and grade 4. You can also divide into covert and overt variety, and where you can have a precipitating factor or spontaneous. Spontaneous will be more common in a covert variety, while in a overt variety precipitating factor will be more common, etc. And acute liver failure will be invariably, acute liver failure is the one of the common cause. Second common cause is photosystemic bypass procedures, and C stands for cirrhosis. So it is called ABC, A for acute, B for bypass, C for cirrhosis. And this is a grading, and you can divide into covert and overt. This is time course, and this is spontaneous or precipitating factors. This is same divided. What will be the findings? Asterexis. Usually in coma you will not be able to demonstrate those flapping tremors, but they will be best demonstrable in grade 1, grade 2 and grade 3. And EEG will be grossly abnormal in 2, 3 and 4, but in grade 1 it may be normal. And this will be all the different grades, and this will be different stages: stable, unstable and unimpaired. You can divide into covert variety and overt variety. So different slides are there. At your leisure time you can go through. There is another condition we call as a delirium tremens, which is very frequently after withdrawal of alcohol. So alcohol is a CNS depressant because it activates GABA, and once it is withdrawn, there is an inhibition of glutamate and NMDA receptor. So abrupt cessation will lead to less GABA activation, enhanced glutamate activity with calcium entry into the neuronal cells, and potentially that cell will die. So during that withdrawal, person will develop severe delirium and there will be tremors. So that is described as delirium tremens, and this is a medical emergency. The person, right from mild symptoms like anxiety, diaphoresis, insomnia, tremors, tachycardia, nausea, vomiting, can develop hallucinations within 12 to 24 hours. Person can also have a seizures, which can be there right from 6 hours to 4 days, 2 days. And there will be withdrawal delirium, which can last for nearly 4 days. The person will have a seizures, series of seizures can develop, and there will be also autonomic activation, including fever. And if not treated, mortality rate can be 20% or even more. You will have to also rule out the misuse of cocaine, benzodiazepine, opioid use, etc. And treatment will require supportive treatment like IV fluids. You will have to give adequate dose of thiamine, and person should be isolated in a quiet room, and person will require sedation either by benzodiazepine or diazepam or chlordiazepoxide. The most common utilized is benzodiazepine and diazepam. This will be the major treatment in case of a delirium tremens. There is another very common encephalopathy you come across in your everyday practice is hypoxic ischemic encephalopathy. You can have a pure hypoxia without ischemia. Very frequently ischemia is always associated with hypoxia. That's why the common term utilized is hypoxic ischemic encephalopathy. And one of the classical example of hypoxic ischemic encephalopathy is cardiac arrest, or we call respiratory arrest, where person develops respiratory arrest will produce hypoxia, and because of cardiac arrest there will be ischemia together, and this will produce a severe brain damage because of anoxic spells. So person will have a severe anoxia, anaerobic metabolism, and there is simultaneously lack of blood supply, so there will be lot of toxic materials which will be produced like lactic acid and other antioxidants, and that will give rise to hypoxic ischemic encephalopathy. So this is a condition where you get a damage to the brain because of lack of oxygen and because of lack of blood supply, and that will produce hypoxic ischemic damage. There is another variety where it is mainly because of vitamin B1, and this is very common because of long-term use of alcohol or chronic alcoholic person with poor nutritional intake, or person can develop also because of poor food absorption, particularly because of GI pathophysiology, and they can end up with Wernicke's encephalopathy. So Wernicke's encephalopathy is acute and reversible encephalopathy due to deficiency of thiamine, or we call B1. And the most common cause is because of poor nutritional absorption or poor intake or poor loss, means excessive loss. Very classical in case of a chronic alcoholics, poor intake in case of anorexia nervosa, intake as well as loss in case of hyperemesis or hyperemesis gravidarum, fasting, prolonged starvation. If a person has undergone GI surgery in the form of major small bowel resection, gastrojejunostomy, etc., GI malignancy, or even case of a systemic malignancy where the intake is less, even person with a transplantation, hemodialysis, peritoneal dialysis, long term hemodialysis is going on, person is likely to develop decreased intake and excessive loss. Even in a person with HIV can also develop decreased intake with increased loss. So indirectly, deficiency because of excessive alcohol use, malnutrition and poor absorption. And there is a classical triad. It is described as a CAN. C for confusion, A for ataxia and N for nystagmus. These are the classical three symptoms and signs which will be seen in a Wernicke's encephalopathy. Again I am repeating, it is described as a CAN, and this is not indirectly, this is a beer can or we call alcohol can, which will produce confusion, ataxia and nystagmus, which is peculiar in case of a Wernicke's encephalopathy. Short form it is called WE. So ataxia, confusion and nystagmus. In ataxia, stance and gait is abnormal. Person will have a polyneuropathy, cerebellar signs, wide base gaze, slow, short space steps, etc. because of cerebellar involvement. Confusion very frequently will produce a disorientation, inattentiveness, etc. and person can also have coma. As far as eye is concerned, nystagmus is very common. Person may develop a bilateral lateral rectus palsy. Gaze palsy can be also seen because of involvement of cranial nerve 3, 4 and 6. Pupil reflex will be poor and maybe sluggish reflex, and you can have anisocoria, unequal pupil, because of one side involvement of third cranial nerve. Person sometimes can have even autonomic system involvement producing hypotension and hypothermia. These are all the different symptoms and signs seen in Wernicke's encephalopathy. We know the Wernicke's encephalopathy is because of thiamine deficiency, so you will require good dose of thiamine, almost 500 milligram TID, which is given for 2 days IV, and then cut down the dose to 250 milligram IV daily for 5 days. Do not administer glucose before thiamine, because if you give only glucose without giving thiamine, it will worsen Wernicke's encephalopathy. But if not treated, means if left untreated, Wernicke's encephalopathy can end up with Wernicke's Korsakoff syndrome, which is a chronic condition as a consequences of Wernicke's encephalopathy, and almost it is irreversible. So Korsakoff syndrome, which is irreversible encephalopathy, we have already mentioned it is because of a late manifestation of Wernicke's encephalopathy if not treated. All the causes of Wernicke's encephalopathy holds true, like anorexia nervosa, hyperemesis gravidarum, GI surgery, prolonged fasting, starvation, malignancy, transplant, hemodialysis, peritoneal dialysis, chronic alcoholism, AIDS, etc. But in this, if not treated early, can end up with Wernicke-Korsakoff syndrome, or sometimes it is only labeled as Korsakoff syndrome. But by and large, we label that as Wernicke-Korsakoff syndrome. So thiamine is playing a very important role in these three different enzymes, that is transketolase, pyruvate dehydrogenase, and alpha glutarate, ketoglutarate dehydrogenase. And this will produce confabulation, that is classical features but not present in all cases. There is marked and selective anterograde and retrograde amnesia. So person forgets memory which is present and past memory. Person can have apathia. Person will have an intact sensorium. Cognitive functions are relatively normal. Social behavior is preserved. Person can also develop dementia. Person is not aware of his own illness. This is very, very peculiar. And it is an irreversible condition, rarely recovers. What he requires is a supportive treatment. And there is also, now they have tried acetylcholine esterase inhibitors and memantine. And there is question mark improvement as far as clinical symptoms and signs is concerned in Korsakoff syndrome. There are all these conditions we have already mentioned: toxic metabolic encephalopathy, uremic, hypertensive, Hashimoto's, autoimmune disorders, particularly Hashimoto's encephalopathy, glycine encephalopathy, which is genetic disorder because of excessive glycine collection in a mitochondria, etc. We should not forget another common, which is very, very commonly will come across in your everyday practice, we call it a psychogenic, where there is a recent stress trigger, person wants a secondary gain, there is a non-genuine finding on examination, and complete neurological examination is absolutely normal, and a full workup if you do regarding investigation, MRI, etc., they are also absolutely normal. Then we label that as psychogenic coma or psychogenic encephalopathy. Ideally, it is not encephalopathy. To make a diagnosis, first medical history and good examination is absolutely necessary. To find out the etiology, blood test for toxins, bacteria, virus, metabolic causes, chemical imbalance, prion levels, etc. should be done. CSF examination for certain viral infections, toxin levels, bacteria, and prion levels in CSF. To confirm the damage to the brain, MRI and CT scan will be useful. And another important investigation will be EEG, which will give you an idea regarding the severity of involvement of brain involvement by showing you changes in electrical activity of the brain. So clinical examination is absolutely necessary. Then there is one simple score which is described as confusion assessment method, where these things are taken into consideration like acute onset or fluctuating course, inattention, disorganized thinking. So questions are asked regarding all these functions, and altered level of consciousness, which you can judge by doing Glasgow coma scale, and then accordingly you find out the negative or positive symptoms, and then you can confirm the diagnosis of altered mental status. Also, you can look for any involvement as far as the respiratory system is concerned in the form of respiratory centers, and if the person has got Cheyne-Stokes breathing or apneustic breathing or Bird's breathing, etc., or even we call as hyperapnea, and tachypnea, which is described in a diabetic ketoacidosis as Kussmaul's breathing. You can also look for pupillary signs, which can be anisocoria, and you can have involvement of the pupil because of damage to the third cranial nerve palsy, which can be very commonly seen because of encephalopathy. And sometimes there can be a misleading signs called as a Carnohan's signs, which is because of the herniation, which will produce false interpretation of the corticospinal tract damage. That is, ipsilateral weakness may be a false sign because of Carnohan's sign, which is because of the corticospinal tract damage at tentorium, compression at tentorium level. Brainstem reflexes should be examined like pupillary reflex, vestibular-ocular reflexes, particularly Dolce movement, and caloric test, particularly cold caloric test. Jaw jerk, corneal reflex, and gag reflex should be examined. That will give you an idea regarding the area of damage. Motor response you should examine like motor weaknesses or decorticate posture, decerebrate posture, and also you should examine the reflexes, asymmetrical or symmetrical, plantar reflex, clonus, and even you can look for what we call as a flapping tremors. We have already discussed this encephalopathy from encephalitis. Again, I am repeating. Encephalopathy, as far as the clinical features is concerned, fever, headache is uncommon in encephalopathy, while they are most common in case of encephalitis, because the commonest cause of encephalitis is viral infection. Altered mental status will be steady in case of encephalopathy, while it will be fluctuating very frequently in case of encephalitis. Focal neurological damage will be more common with encephalitis, while it will be generalized in case of encephalopathy. And seizures will be also generalized in case of encephalopathy, while in case of encephalitis, seizure good number of time is a focal and then can be generalized. But neurological damage is invariably focal only. Laboratory finding, we have already told you, it will be more findings like in a blood, CSF will be more common with encephalitis. EEG will show you generalized finding in case of encephalopathy, while it will be localized in case of encephalitis. MRI will be by and large good number of time normal in case of encephalopathy, but in case of encephalitis, always and always you will get some focal damage which will be detected by MRI or by CT scan. As far as management is concerned, will depend upon the etiology. So medications are usually done for decreasing the progress of the damage, and you treat always the underlying cause which is treatable, say like wernicke's encephalopathy, hepatic encephalopathy, uremic encephalopathy, hypoxic encephalopathy. Those are treatable and good number of time they are reversible. So nutritional supplements, very rarely we require a surgical intervention in only few cases. As far as complications is concerned, will depend upon the etiology, because some conditions are irreversible damage to the brain. In those conditions, you will have irreversible damage to the brain and person may not recover. And in some of the encephalopathy, they are highly fatal. So complication will depend upon the type of damage and etiology and severity of damage. So in general, I have tried to cover up as much part of possible in encephalopathy. I feel this lecture will be helpful to you in your theory, in your everyday practice. It will be very, very important. And if you like this lecture, don't forget to press button like, subscribe, press bell icon, and you can share with your friends also. At the end, thank you very much for taking out time. I know that your time is very valuable, and I also appreciate that you have spent some of the time with me. See you in next lecture. Also, if you got some suggestions, you can send those suggestions. I'll try to improve. All my video lectures are mainly for educative purpose. Do not consider, always consult your doctor for expert opinion.